everybody. I'm going to start 2 minutes early with the introductions so that we don't get interfering with our very short time that we have to talk. So I am Michelle Petrak, the Director of Clinical Audiology with Interacoustics, and we're very proud and happy to sponsor this short seminar this morning. We have two very distinguished speakers here with us. So our first speaker will be Susan Whitney. Although she doesn't need an introduction, I'll do it anyways. So Sue is a professor and a physical therapist in otolaryngology from the University of Pittsburgh. And she's going to give us a little chat about some of the newer technologies and innovations that are happening in the industry now and things that are new and exciting for our clinics. And then our second speaker will be Dr. Sharon Cushing, and she's an associate professor at the University of Toronto. And she's going to be talking on vestibular impairment in children with hearing loss bearing the load. So how we're going to handle this is we're going to let the two speakers do their talking, and then at the end I'll come back around with the microphone, and then I'll take any questions at the very end. So at the very end, our two speakers will come up. I'll walk around with the microphone if you have a question, and then they can answer those for a few minutes afterwards, okay? So very happy to get started, very short amount of time, so Susan Whitney will kick us off.
Once I start my timer, I'm ready to roll. Okay. So what I planned on doing was actually showing movies for most of this so that you can see some of the technology that people were using. And in terms of disclosures, I'm on the board of the American Physical Therapy Association, have the unofficial Speakers Bureau for Interacoustics. I speak a lot for the Neurology Academy of the American Physical Therapy Association, and I receive funding from the NIH and also the U.S. Department of Defense. So these are some credits from some of the companies and people who've given me pictures and or movies to share with you today. And I'll go through, and as I see them, I'll kind of acknowledge them as we go through. But when you use other people's technology, you need to acknowledge them. So what we're going to talk about are some of the technological devices, and I'll try and quickly, if I can, give you some idea of what looks promising out there, and there's almost no data for any of the new technologies that I'm talking about, all right, in terms of how well they work and how they should be dosed. So the most typical thing that people do is use optokinetic stimulation. So when we wrote the clinical practice guidelines for the American Physical Therapy Association that were published in 2016, we talked about optokinetic exercises as a different form of exercise, and people kind of call it habituation, but it may actually be different in terms of what happens in the brain when you receive optokinetic stimulation. So what's happened is PTs around the world, physiotherapists, are using disco balls. I have 5 different disco balls in my clinic, 5, okay? So I have ones that are easier for patients to use. I have ones that are high contrast. I have ones that can go in pitch, roll, or yaw. So we all believe that these work, but there's not a lot of data, all right, about this. But if you ask physiotherapists, they're going to say that these things do help, and eventually we're going to have some data to figure out which of these work optimally, and do we need a $5 disco ball, or do we need something more intensive? So if you look in the upper, I don't know what this will show, but this is what some of my pediatric friends do. They actually roll these little things that's on a stick. You can make that yourself, and you can do it in all directions. Some of you come from countries that have lots of money, and some come from countries where there's no money. So these are some low-tech things that one can do. And these are just the typical stripes that we use in the clinic to look at, put an X in the middle and do those VOR exercises that we do. So there are a lot of apps. The world is moving to apps. That's one of the take-home messages. If you hear nothing else, everybody's going to be treating with apps. So this is called optokinetic. And if you go in your little app store on your phone or your pad, you can make it large. The stripes, you can make them small. You can make them red. You can make them blue. You can make them black. So you can connect this up to your TV at home and have patients do it there. So you need to think a little bit outside the box, because in even developing countries, almost everyone has cell phones, and most people have the ability to get on the internet around the world now. So the world is truly changing. So I want to show you, these are the kind of things that people are using. This is a movie that I made actually at a Las Vegas hotel. The floors are horrendous there, and they're forcing your vision up on purpose, right? So this is just walking through the hotel looking at the floor, which is awful, isn't it? So these are the kinds of things that physiotherapists around the world are doing. They took some of the work that Marisa Pavlov published from the UK, and what they've done is gone to YouTube and are using YouTube videos to direct care for children and adults to expose them to more difficult visual scenes. So some of this work kind of started at the University of Pittsburgh where I work. So we built a huge virtual reality lab, and we had people stand and be exposed to different scenes. So these were some of the early scenes that we exposed children to and adults. And Margareta Castlebrandt's here. She did some of this work at Pitt with the children. And here's just another example looking at, so we do have some basic information about postural sway and what happens when people are exposed to scenes. So there is science behind this related to people with vestibular disorders, but we really don't know dose and intensity. And that's what, we just got funded by the Department of Defense to actually look at dose and intensity of vestibular exercises to try and determine what's better. Do you really push them hard and make them highly symptomatic and they get better faster? Or do you go with a lower dose? So we're actually looking at dosing. We'll be doing that over the next 2 years and hopefully have some answers for you. So most of you hear about grocery stores from your patients. All of us have tried to simulate the grocery store in different ways. Here's an example. This is one of the most impaired people in the studies that we did, that she had an uncompensated unilateral peripheral loss. And what you see, let's see if I can show you. Here's her head. This pointer is not the best, but you can see how much lateral sway she has. She's actually pushing the grocery cart. She's actually on a treadmill, and she's walking through the store. So what all of us are trying to simulate is this kind of activity. How do you put people in a grocery store for an exercise when you can't physically watch them do that? And in this case, what we've really looked at is colors. We've looked at reflections, and we're not sure what's most critical. And what a lot of people are doing now is they build it into the Oculus Rift or into other technology to try and simulate this in persons with vestibular disorders, because it makes them so symptomatic. So in our design, later designs in the grocery store, what we did was we actually went and talked to patients and said, what's easy in a grocery store? What's difficult in a grocery store? So we built a grocery store to their specifications with our virtual reality. And so this is kind of the medium aisle, and there's a really difficult aisle. And the difficult aisle has small objects and lots of contrast, very difficult for folks. So there are companies all over the world that are working on technology, and one of them is this company from France called Virtualis. And I'm going to try and show you at least clips of some of these things that people were doing. And this was given to me by the company, all right? So realize some of these things are like ads. It's just the way life is, all right? But I want to expose you to it. So you're going to see, hopefully, some action here in just a minute. So this is for seasickness. Yeah, I'm rocking and rolling already. I don't know about you. My patients would be ill. That's the one that most that made me crazy looking at it. So there's just some really neat things. So people are using situations that increase symptoms in people with vestibular disorders, putting them in places where they do have symptoms and seeing how they respond. This one's nasty. Those of you who have height issues, close your eyes and the feeling will pass. All right, so there's fear of heights. But a lot of my patients do have fear of heights too. It's pretty dramatic, isn't it? Now you're going to go out, and then I'll stop it, I promise. Woohoo! So this is a cool one. So they've done a really, really nice job of using their technology to advance. And I wanted to show you too, I think this one will show you, they're also starting to, I'm working on this with a company too, looking at eye recognition software while viewing visual scenes. So this is coming. This is going to come through head-mounted devices. It's going to be on apps, on computers and iPads. So this is clearly, this technology is here. It's just a matter of putting it together in the right combination, and it will work. Okay, let me show you another one. Let's see. So this is technology, I don't know whether it's downstairs or not, but Burtek has come up with this device, and that actually is a movie. It's hard to see, but as he sways, the scene moves. My friends who use this all the time say that this technology is amazing, that they're using it all the time in the clinic, and that they really like it. So that certainly is an option, the idea of using visual scenes and looking at postural control. I'll see if I can get the next one. So no matter what, whether it's an HMD or kind of this visual scene like this, everyone is trying to figure out how do you replicate the situations that increase people's symptoms who have vestibular disorders in order to slowly get them used to being able to do that in a normal way in their real lives. And that's what people are doing in terms of rehabilitation. Okay, this is actually part of Dr. Hoppus's work, who's sitting here, who won the award last night. But what we've also been doing, not necessarily in terms of rehab, but this could be a rehabilitation device. This is using optokinetic stimulation, and what we've been doing is looking at brain function. All right, so what lights up in your brain with FNIRS when we expose people to visual scenes? And she'll tell some of that story actually during GATE. We're using simple things too to figure out this stuff all works. So this visual vertigo analog scale was originally developed by Longbridge, who's sitting in the audience. We're using questionnaires like this to figure out if this stuff works. All right. So how does being under fluorescent lights bother you? Busy stores, etc. So these kind of tools are very powerful to find out if these high-tech interventions are effective. People are still using the Wii Fit, so that type of technology is clearly out there. People like games. You're going to see more and more gaming technology. So as apps develop, you're going to see games. You're going to see feedback. People like to win. People like to know how they're doing. And that's what's happening in the world. You're going to see tons of developments like that over the next 2 to 3 years. I'm working on some stuff like that. The Department of Defense in the United States is actually supporting some of that work for several different companies, and there's going to be some really neat things that develop. And there's data that says that working on the Wii out of the Switzerland group that these things can actually help improve postural control in people with vestibular disorders. All right, the VR cardboard. My buddies in South America are using it all the time. You drop your little device in, and you can do VR at home. So that's clearly going to happen. It's going to be big time. You can buy an Oculus Rift, or you can buy your $10 cardboard. They both work. All right. So does this work? Yes, it does seem to reduce symptoms. Dosing and progression rules are unknown. Technology is real life, and it's engaging. So there's other things that people are using to try and do repositioning maneuvers. So that's a movie. Here's the Omniacs, which is another device that I don't know if that's what it was downstairs because I didn't get over to see it, but looks similar. You're going to see technology to try and change the gain of the VOR that was discussed yesterday in the meeting upstairs, where we're trying to you can change the gain of the VOR. You can change it on one side, and that technology may work. Let's see here, and then I want to at least show you one of these. So this is some technology here in the United States, where they're actually moving people. All right, and then she's looking at the target. Now this one is too long, so I'm going to try and show you the advanced training one, and it's pretty dramatic. So I wanted to show you phase 1 and phase level 18. This is called the gyrostim. So people are doing wild things around the world to try and improve the vestibular system, and that would make me, you need the plastic around that for me. Okay, you get the drift? Okay. And then vibrotactile feedback. Now, I want to show you one other thing in my last minute or two, and it worked before. I want to show you that this is the technology that people are using now for exercises. So I actually send a link to my patient with exercises, and it worked earlier. It is supposed to be moving. Oh. So this group, and there's probably other groups around the world, has, I think, 5,000 exercises on it. And what you can do, and they're in English, but they may be in other languages also. The idea is that we're sending links to patients. So if they have a phone, a cell phone, whether they're 80 or they're 10, we send them a link, and they do their exercises, and they can actually see it, and they can review it again and again, and hopefully get it right. Because we have a lot of difficulty with exercise compliance because they don't remember what they're supposed to do. The vibrotactile feedback is absolutely working. I'll finish this phrase and quit. We just published a paper here in 2018 with the vibrotactile feedback with a cell phone in the home, with remote technology, and it absolutely works. So in terms of improving postural control and balance. Thank you.
Can you hear me okay? There we go. So now that Sue has told us how we can treat individuals who have vestibular impairment, I'm going to put into context a little bit of what we're seeing in children and focusing on specifically those children who have sensory neural hearing loss. These are my disclosures. And this is our cochlear implant research team back at home at Sick Kids in Toronto, and it's really a credence to all their hard work on a daily basis that allows me to be here in beautiful Sweden today. So I'm going to start off with this video, because what are we talking about? Load. And so this is a young boy with Usher syndrome. He's bilaterally deaf and has implants and has no vestibular function that's measurable. And here he is on a scooter. Watch how he comes around the corner. The leg's going to go out. There he goes. And so many people say this, that, well, what are you talking about? These children do fine. These children with congenital vestibular deficits are able to ride a scooter. And so what we're really going to talk about is how this child is capable of doing this without any intact vestibular function. And the answer to that is that he's using other mechanisms, and the cost of those other mechanisms is his cognitive load. So let's go on a little journey. So we're going to look at cognitive load, and you can look at cognitive load from a lot of different frameworks. And what we're going to talk about today is balance and navigation. That's the framework that we're going to use. And so let's start off by talking about how we measure balance. So one of our old standbys is the Brunick-Oseretsky test of motor proficiency. And I'm a surgeon, I'm not a physiotherapist, but even I as a surgeon can administer this test. So it speaks to its simplicity in the context is it's something that we do in the clinic all the time. It takes very, very little additional equipment. It's very inexpensive, and it's great because it comes with age and gender standardized norms. And so it's very, very effective. I'm going to show you a little bit of what it looks like to administer this test. And so these are two children. Again, the little boy on the right side of the screen has Usher syndrome, and again is bilaterally implanted. And these children are matched for gender, age, and t-shirt color. And what you can see is that they have vastly different balance ability. So this is how good this test is, in that anybody sort of watching, we administer this in the clinic area, and my administrative assistant has a viewpoint of this, and she can tell me who has normal balance and who doesn't have normal balance just by watching these children. And you can see that it's very, very sensitive at picking up children with vestibular disorders. The kids like to do it, and again, it's a very simple and easy task. So that's really our go-to in our clinic. And so the first thing we're going to think about with respect to sensory input for balance and navigation is hearing. That's where I do spend a lot of my time, surgically and clinically. And so when we think about hearing, we don't always think about hearing as an input to balance, but I think it's an important one. And here's a little video that demonstrates this. So again, this is the same child. She has the same vestibular system in both videos. In one video, she's wearing one of her implants, and in the other video, she's wearing two of her implants. And Mom captured this because Mom knows she wears two different processors and the batteries die at different times. And so Mom says, I can tell when one of her batteries goes out in her processors, and it speaks to the idea that hearing is an important input for this child in terms of her balance abilities, which are generally incredible. She has an intact vestibular system, but hearing is still very important to her. When we think about single-sided deafness, and later this morning I'm going to speak fully to this topic, we also see that children who have single-sided deafness have balance impairment. And here we have children with unilateral hearing loss, and this is a group of normal hearing controls. And it's important to notice that these children have these impairments even in the setting of single-sided deafness. Now, what about the vestibular system? Certainly it's the building block that we think of for balance and navigation. And we know that children who have bilateral sensory neural hearing loss have a very high prevalence of complete areflexia. So almost 40% of children who walk into my operating room are going to have no balance function. And so vestibular impairment is the single most common feature associated with sensory neural hearing loss. Now, children don't care what their lateral canal is doing or what their otoliths are doing. What they care about is navigating the playground. And so this is where the BOT testing comes in, where we look at what the impact is on balance function. And so here we have children with normal hearing. We have all comers with hearing loss, some of whom have intact vestibular function, some of which who don't. And this is our group of children who have bilateral vestibular impairment. And what you can see is that these children, their balance skills plateau out at the level of a 4.5-year-old. And that's why sometimes as clinicians we miss it, because think of all the things a 4.5-year-old can do. They walk into your clinic, they even run into your clinic, but they probably can't ride a bike without trainers. And so that's where there's this dichotomy of they have troubles, but we really do have to look for them. And so let's shift gears away from the inner ear and look at vision. And the reason we're looking at vision is that these children have developmental deficits in hearing and vestibular function. So what happens if you have a developmental deficit in vision? Well, we looked at balance function in a group of children who had strabismus and amblyopia. Again, normal hearing, normal vestibular function, and these are their balance skills. And so in comparison, what you can see is they are worse than our group of children with unilateral hearing loss, and pretty not so dissimilar than our kids with bilateral vestibular loss. And so it speaks to the idea that if you are born with a sensory deficit, the way that you put together your image of the world is going to be very different than an adult with an acquired loss in sensory function. And that's really what we're thinking about. And so this is what, again, life looks like when you have vestibular impairment. This is another child with Ushers, and this is at our Cochlear implant skating party. And we captured this video because we thought it was pretty remarkable that, again, it's a good Canadian story, a child with no vestibular function up on skates. And it's amazing that he's able to do this. And then as he comes around the corner, this is what we see. And so if you look at how he fell, his arms did not go out. He took that one on the chin, and it speaks to the idea that he doesn't appreciate, because he has a congenital vestibular loss, how to fall. He doesn't have any of those reflexes that we would otherwise have, or that an adult with an acquired loss might have. And so we have to think about things differently in children. And so there's been a lot of work lately, particularly in the implant world, looking at cognitive decline. Now, I haven't looked after an adult in a very, very long time, but I think that this message really speaks to us. And one of the things that has been interesting is this concept that we might be able to modify cognitive decline by treating sensory impairments. There's a lot of work in the implant world, and I'm happy to see at this meeting there's also a lot of work in the vestibular world, and that we can potentially modify the rate of cognitive decline in adults. Now, what I'm interested in is not cognitive decline, but rather how you build a brain in the presence of a sensory deprivation. And so that's really what we're going to focus on the second half of the talk. And so, again, I'm a simple surgeon, and so for me to understand how we build a brain, I like to break it down. So essentially, we have a sensory stimulus coming from the environment, and our senses pick that up. We then process that high-fidelity representation of the environment to create patterns that we can recognize over time. Sometimes we need more information from the periphery, and we ask again and get more information to create this faithful representation of the world around us. So let me give you an example. Where I live in Toronto is very near a park, and there's one of those old-fashioned ice cream trucks that comes by and plays this little song or music. And so, you know, for the first 17 months of my son's life, he heard this music probably almost on a daily basis, with the exception of the winter when the ice cream truck doesn't come by. But I don't know what his brain did with that sound, but I can tell you that in and around 17 months of age, I thought, you know what, this kid is old enough for ice cream. And so I brought him out for an ice cream cone. And in that moment, my son's brain changed. He associated that sound with the deliciousness of ice cream. A single ice cream cone changed my son's brain, and that's what we really have to think about when we're thinking about sensory deprivation in children. Now, what if my child had hearing loss? I suspect he'd probably still love ice cream because he comes by it naturally, but he wouldn't have that auditory association. And we know that we can overcome cochlear loss with implantation, but what about the vestibular component? And so things are much, much slower when we have a cochlear loss, and our ability to capture that information from the periphery, again, everything is slowed down, and it increases our cognitive load. So can we do something about that cognitive load by improving hearing? Well, the answer is yes. And so we've looked at the balance effects of cochlear implantation. And I'm going to point out, I've cut the axis here. I've done that on purpose because these differences are so small when you go from implant off to implant on. They're statistically significant, but you just change the child's balance performance only a little tiny bit when you give them hearing. And so what about vestibular loss? You know, what does the world look like when you're navigating with vestibular loss? Well, I'm going to show you a video of our child with ushers skiing, trying to take a ski jump. So here he is. That's what it looks like to take a ski jump when you have no canal function and no otolithic function. And so the question is, can you overcome that with effort? And the answer is yes. And so this child spent days practicing this jump. I don't know how many hundreds of times he took it, but the cost to him was that he didn't hang out with his friends. He didn't do his homework. There was a huge load associated with him succeeding at doing what his physiology said that he shouldn't. And so the question is, can we make that easier for him? Can we reduce that effort by giving him more vestibular input? And I think the answer is yes. And so some of the work that we've been looking on is, can we use the implant to evoke vestibular end organ function? And so what we've done is we've used the implant to evoke VEMPs. And so here's one example of an acoustic VEMP and then an electrically evoked VEMP. And the exciting part is that we can evoke electrical VEMPs even in individuals where the acoustic VEMP has been obliterated by the etiology of their deafness. Evoked VEMPs are faster, not surprisingly, given that they're electric. In terms of the end organ function, what about the percept? You know, certainly having a vent probably helps you land the ski jump, but knowing where vertical is certainly helps you land a ski jump. And so the next thing we looked at is whether or not we could improve SVV, or the subjective perception of verticality, by turning on the implant in the same way that we did to evoke otolithic function. And so again, this is the Chronos system that's being used here. And again, if you have an abnormal visual vertical, you either tilt left or you tilt right. And so this is the data. What it shows is that we have a group of children who are left leaners and a group of children who are right leaners. And when we turn on their implants, we can shift the left leaners right and we can shift the right leaners left. So we can restore their sense of verticality by using electrical stimulation from their cochlear implants, which is very exciting. And so can we take it a step further? Can we give them the information that their brain is hungry for? And again, I'm going to speak to this later this afternoon, when we have a device that we've been looking at that provides head-referenced transcochlear stimulation in order to help improve that high-fidelity representation of the environment to push these children's balance skills one step further in the setting of a congenital loss. So, in summary, certainly these children demonstrate increased cognitive load, and that has a huge impact on development. These are not adults with acquired loss. They are multisensory deficits which add to that load, and I think that we can use their already implanted cochlear implants to not only reduce the auditory component, but also the vestibular and balance component of that load. Thanks very much.
All right. Oh, sorry. So a big thank you on behalf of Interacoustics to both of our wonderful speakers, and I'll take questions. Well, I won't take questions. I'll hold the mic for anybody that has questions for these guys to take. So any questions at all? No questions. All right. Oh, good. I was beginning to think that they taught it so well that there was no questions.
I think it was a brilliant presentation from both of you. I have a question for Sharon. As you know, probably we are busy in developing vestibular implants. And so when you give your fantastic presentation, I'm challenged because I think, of course, logical thing, do we really need them? What is your opinion about that?
You know, I would say absolutely yes.
Yeah.
And I think there's different populations. So I think there's adults with acquired, bilateral vestibular loss with and without hearing, and I think there's a solution for those. And there's also a lot of children who are born with congenital loss. And I think treating children with loss is a little bit trickier. One, because you have to be certain of the impairment, and again, we're getting better and better with our testing techniques, and you also want to be careful with whatever residual function that they have, and so I think that's where we've looked for a solution that potentially doesn't involve implantation, but you know, these children do need something, because if you just scratch the surface, you might miss it, but you know, you can't learn to read if you can't keep your vision stable and you can't sit still in your seat. And so I think that there's lots of room in many different patient populations, so yes.
Yeah. So, but nevertheless, I think it's an amazing, indication that you can reach a very high level of improvement simply by training and modifying the cognitive load. Thank you.
If you could just hand the microphone down.
Thank you for these very good presentations. I have a question. So you showed that training must bring the patient in a situation to get the border of what he is able to do. But the simulations you have provided are vestibular stimuli. What about other stimuli, let's say, at the same time to present a cognitive task according to the concept of dual tasking as a training situation? That is one question. And a comment to the other presentation. I would reinforce your comment on hearing, cochlear implantation and balance, especially your comment on the subjective visual vertical. We were able to show that same in more than 20 patients which were defeated by the labyrinthine function for a therapeutic issue, and we saw with and without cochlear implantation the same effect you have presented, and more than 10 degrees uprighting of the subjective vertical with cochlear implantation active, with one intact and one switched off ear.
Fascinating. I'll take the first question, and that is, I think at least all the physiotherapists I know in the world are doing dual tasking, meaning some of us do simple tasks like the months as you walk, or we'll do serial sevens starting at different numbers. We definitely see a change in gait behavior when people have to do dual tasking. I certainly In terms of rehabilitation, I would never start with that because it can cause people to fall over, because when you add the cognitive load to someone who's compromised already, it can make them at risk for falling. So you have to, I don't think anybody in the world knows exactly when you should start to do that, but people who have lots of experience, I think, are pretty good at doing that. So there are tests, for example, that I'm sure you're aware of. You can do a simple test like the timed up and go, which is stand up from a chair, walk 3 meters, come back and sit down. You can do it carrying things, which is a dual task, and you can do cognitive tasking too. So there's absolutely no doubt that, and there's emerging evidence that vestibular disorders can affect executive functioning. And so what we try and do in rehabilitation is try and get them to the point where they can dual task as they actually move.
I think that the comment about SVV, what resonates for me is that, in the world of, audiology and hearing, we've long relied on behavioral testing, and I think the same should be true of the vestibular world, where we need to know what the end organ is doing, but we also need to know what the output of the system is. And so tests like SVV that speak to that behavioral component, I think are really key in looking at outcomes.
And one more question
Yeah, I think I just wondering that both of you a fantastic talk and good is rehabilitation or habilitation. I'm just wondering, the table tennis, Chinese ping pong. Do you think that will be? Sorry, that will be a good training. We compare this because ping pong is a quick switch.
I almost got taken out there.
Yeah, I think that would be an extremely difficult task, ping pong, for some folks. But if you, just like with everything else, you start slow and then increase, and especially if you can decrease the variability by maybe, how you can bend the table up so you actually go, it goes against the board and comes back, so it's more predictable. I would start out with predictable ping pong and then less predictable ping pong and see if they can do it, because it's very similar to the tasks that we've talked about. Fun is where it's at. So if you can get people to do things that they're motivated to do, it works. You'll see in the world of physiotherapy around the world, we're talking more and more, we're not psychologists, but we do use cognitive behavioral techniques, and I also use a lot of behavioral interviewing to try and motivate the patient. So if ping pong is what you love, I will try and get you to do ping pong, all right? If you've never done it before, I'm not sending you to the ping pong table. But you will see that there's, regardless of what the pathology is, if you use what's called cognitive behavioral techniques with people with dizziness, they get better faster. There's absolutely no doubt about it. And it's engaging the patient in their care, which is what you do also with your children. It makes a difference in the outcomes.
Okay, one more question.
So Sharon and Sue, that was great. First for Sharon and then a comment for Sue. So Sharon, we like to think all of our implants work, but they don't. And our audiologists remind us all the time that occasionally one side is not working nearly as well as the other. Have you looked at kids who, have bilateral implantation with poor function in one of the implants, and what their BOTs look like versus the kids who have great function in both the implants without a vestibular impairment?
We haven't, and it's funny because I continue to be reminded to go back and look at the data. Probably the biggest definition that changes outcome for us is duration of deprivation, and so we have this cohort of long delay sequentials when we made that transition, and we know that their cortex is asymmetric, and so what we need to do is go back and look at those children versus simultaneously implanted children where we know we've promoted cortical symmetry. We also have this new cohort of kids with single-sided deafness that we're implanting, and I think that that's going to be key at looking at, both the implanted group and the non-implanted group and how their performance relates from a balance in the long term.
And then the comment for Sue is the other way it works as well. So we have individuals with cognitive dysfunction after mild traumatic brain injury. And when we give them vestibular rehab and only vestibular rehab, their cognitive function improves. Now, of course, there's an element of time because the rehab takes some time. But if you just look at individuals in the same period of time that have not undergone rehab, they don't do as well cognitively. And, I always tell people it's like if you're being chased by a tiger in the jungle and you fall down, you're dinner for the tiger. It doesn't matter if you can balance your checkbook or do anything. So we think, going back to this load issue, that it goes both ways. You have a vestibular problem, you don't have a lot left over to keep yourself upright, or if you're spending a lot of energy keeping yourself upright, you don't have a lot left over for cognitive function.
Right. So I think that we are close to over our time. I see one more question while I'm walking back, though. Remind people that subjective visual vertigo presentation will be happening at the booth. So people that want to come by and see that, SBV will be doing that later this morning.
Thank you. Thank you for really inspiring talks. We've been doing research on how fast the balance system adapts to virtual reality, and it's really fast. So how about your patients, Susan? How fast do you think they go from thinking they are walking in a store from believing that they are watching a movie walking in a store?
I think it depends on the technology you use for the level of immersion that you're going to get. One of the concerns that I have about virtual reality is vergence in older adults. So most of the people who have, at least a lot of the people I see with vestibular disorders are older. And with the technology, you basically have to verge at probably about 5 to 6 centimeters for a head-mounted device. And older adults' vergence decreases increases. They may focus out here. So I'm not sure yet whether the technology is going to work as well with older people because of their problem with vergence. So that answer I don't think is out there yet.
So thank you both very much. We much appreciate it.